4.
3, 2, 1. Hello, everybody, and welcome. Welcome, you virtual audience, to the Coronavirus in Texas, our virtual event series from the Texas Tribune. As with most of the state, the Tribune has temporarily paused our in-person live events, but we're moving the conversation online with this series of virtual interviews shot live from the living room. I'm here with Dr. Peter Hotez. He's the co-director of the Texas Children's Hospital Center for Vaccine Development and dean of the National School of Tropical Medicine at Baylor College of Medicine. And we'll be discussing the impact that the current outbreak is having on our healthcare system until about 8:45 this morning. We'll also be taking your questions throughout the conversation, so be sure to send us questions at trib.it/Peter-Hotez-interview, or you can tweet at us using the hashtag AskTrib. We want to thank our sponsors for supporting today's conversation: Blue Cross Blue Shield of Texas, Community Health Choice, and Methodist Healthcare Ministries of South Texas. We also want to thank Univision and KXAN, both of whom are streaming today's conversation, for their media support. Though donors and corporate sponsors underwrite our events, they play no role in determining the content, panelists, or line of questions. And if you want to keep tabs on the latest coronavirus news in Texas, please subscribe to our evening newsletter for updates. You can find the URL at trib.it/coronavirus. So here we have Dr. Peter Hotez. He's the co-director of the Texas Children's Hospital Center for Vaccine Development and is the founding dean of the National School of Tropical Medicine at Baylor College of Medicine. And he has wide expertise in vaccine development and neglected tropical diseases and is leading several projects to develop new vaccines. Dr. Hotez, thank you for joining us.
Oh, thanks for having me this morning.
I thought we could start with the news of this week. We've started to see pushback from top officials, including President Trump and Texas Lieutenant Governor Dan Patrick, about the severity of the pandemic versus the sort of economic consequences of social distancing. We're seeing comments like it's not worth inflicting major economic pains to halt the spread of the disease. As an expert, what do you make of that rhetoric?
Well, I do in some ways, empathize with the president, the governor, and lieutenant governor. I mean, it's heartbreaking, right, to see such a robust economy take such a hit because of this epidemic. And I understand the sense of urgency they feel to get this economy back on track. So, you're seeing a lot in the media attacking those individuals, saying, this is not the time to be talking about the economy. But, it's important to put it out there. Here's what I've been saying. I said, I understand the sense of urgency. I understand how devastating this is, especially for people who are losing paychecks and the unemployment is going up. And that's having a huge psychological impact. So let's not underestimate the psychological impact of this epidemic. But here's why I don't think we should set a firm deadline for saying that we're going to do this by Easter and lift all of the social distancing recommendations and restrictions. This epidemic we're still in the, I'm sorry to say, still in the early stages of this epidemic. We really need to get a better sense of where we're headed with this. I mean, New York right now, we'll talk more about New York in a bit, but it's getting really hammered right now. The hospital systems are being overwhelmed. We don't have enough ICU beds. We don't have enough regular hospital beds. Healthcare providers, doctors, nurses, respiratory therapists are all getting sick. So we're losing personnel. This is the nightmare scenario that many of us work so hard to avoid. So what I've been saying is, look, let's get this epidemic in New York under control. Let's get a notch in our belt saying we scored one public health victory, showing that we can actually control this virus. I think that's number one. And number two, and that's going to take a few weeks. It's not going to happen by April 12th. What I've been saying, look, let's give it at least 30 days. Let's give it to the end of April and then make a reassessment of where we are. Because by buying that time, we'll also find out if this epidemic is popping up in new cities. We're already seeing what's going on in New Orleans right now. And we'll talk about that this morning. The case fatality rate is unexpectedly high in New Orleans, and maybe this is a new dimension of this epidemic in the South. By the end of April, we'll get a better sense of how many hotspots there are, and then we can make that kind of assessment. But don't set a time now. I know that was a long-winded answer, but I like to explain my thinking behind all of this.
No, I totally understand. It's interesting though to hear reassess at the end of April. Maybe it stands sort of in contrast. I think Governor Cuomo in New York, like we were talking about, has told people to expect social distancing measures maybe to last up to something like 9 months. I mean, do you see that being in the realm of possibility when you say we'll reassess in a month?
Well, remember what this is. This is a new virus agent, and we don't really know. We haven't been through a whole year of this virus. So we're still in a steep learning curve trying to figure out what this virus is. We don't even really know all the modes of transmission. We don't know if there's a seasonal component to it, and if there's a seasonal component, does it go down in the warmer months and then come back again? So we really can't make firm statements either way every time. And this is what new virus agents do. They set you up to make you look bad. They make epidemiologists and scientists like myself look bad because they always take new turns and twists. And they make government leaders look bad because it's the hardest thing we do as a nation to fight a new epidemic. And so I'm looking at the long view from what I've seen over the last 20 years, beginning when we had anthrax in 2001, SARS in 2003, MERS in 2012, H1N1 2009, Ebola 2014, Zika just recently in 2016, and now this one. We have to collect information. We have to collect data. And I think what we need to do is take it in small bits. It's really hard to know what's going to happen in 9 months. We have a lot of mathematical models, epidemiologic models, but the models are only as good as the assumptions, and the assumptions are still weak because we don't have a lot of details about this virus. So when I see models saying we're going to have half the country infected or 70 million infected, yeah, it may be true, but I've worked with I'm not a modeler myself, but I've worked with modelers in order to look at the impact of our vaccines that we make for parasitic and neglected diseases and now coronavirus. And what's always impressive is how those projections can change dramatically just by small tweaks in the assumptions. So that's why I would say a month from now, things may look very different. Things may look far worse than they are right now. But there may also be, we can't dismiss the possibility that because of the social distancing, we are making a difference in this epidemic. And then you got to decide, okay, well, then if there is an impact, how long at what point do you let it up, or do you risk going back to something terrible happening? And we're seeing this now with some parts of China and Singapore and elsewhere, where they were very aggressive at social distancing. They scored a public health victory. They let up, and now the virus may be coming back. So there's a lot of things that factor into these kinds of decisions.
I want to visit a topic you touched on briefly, which is healthcare workers becoming ill. We've seen doctors in other parts of the country already becoming critically ill in some cases. And you have said that our ability to protect frontline health workers is our weakest link right now in the U.S. response to COVID-19. What can we do to protect healthcare workers? And by we, I mean us as individuals, and then collectively, what can we, as a society, as government, do to better protect our healthcare workers who are being exposed to this virus and in large quantities?
Yeah, I mean, this is one of the things that I saw when when COVID-19 was emerging out of China. One of my first responses was, oh my God. This one is going to be very bad for hospitals and healthcare workers. And I said that because that's what coronaviruses do. We saw this with SARS in 2003, the original major coronavirus pandemic. Then we saw it with MERS, Middle Eastern Respiratory Syndrome, in 2012. That's the modus operandi of coronaviruses. They strike hospitals. They're highly transmissible in hospitals, and they knock down the healthcare workforce. People get sick and sometimes seriously ill. And they're also destabilizing because you have a situation where colleagues are taking care of colleagues in the intensive care unit. And we just had a little hint of that in Dallas in 2014 when we had the two nurses in the ICU in Texas Presbyterian Hospital in Dallas get very sick. We saw how destabilizing that was. And now this is going to play out on a much larger scale. And sure enough, a paper came out in JAMA, Journal of the American Medical Association, finding that about 1,000 healthcare workers got sick in Wuhan, a huge number. And the interesting finding there, about 15% developed serious illness, or even were in intensive care units. So sicker.
Do we know why that is?
Sicker than you might expect than on the basis of age. I don't think we know whether it's underlying stress and an ability for them to take care of themselves, and they were sort of in a weakened immune state. I think it's more likely maybe there's being exposed to very higher doses of virus in that hospital setting. You know, if you're sticking your face into someone as you're trying to intubate them, maybe they're getting high doses of the virus. We don't know. But then we saw it again in Europe. Just looked at the numbers. There's been more than 30 healthcare workers who have died in France, Spain. Sorry about the sunlight there. France, Spain, and elsewhere in Europe have died. 30 have died, so thousands again. So we knew this was going to happen, and throughout this epidemic, I've been given this wonderful opportunity to be a national voice, and I've been on MSNBC or CNN or Fox News every day, and believe me, it's not easy going from MSNBC to CNN to Fox News. That in itself is kind of interesting. But the mess, and I've used that opportunity to highlight where I see certain issues are not being addressed. I use this to really highlight why our nursing homes are not being protected and what we saw with that terrible situation in Kirkland, Washington. But the other is to sound the alarm about the risk of healthcare workers. And I guess my question is, in these cases, I've used very provocative language to really wake people up. And I said, I think it was on CNN New Day, I said, look, if we allow significant numbers of healthcare workers to get sick and you have colleagues taking care of colleagues in the ICU like we saw in Europe, it's going to be lights out. That was the term I used. Sure. And that woke people up, because I really believe that if healthcare workers don't feel safe coming to work every day and large numbers of the workforce are getting ill, then that's going to be the major hurdle in fighting this epidemic.
Is it a question of equipment? Is it that we don't have adequate supplies to keep them protected? Is there some way to address this, like a tangible solution?
It is lack of equipment, lack of personal protective equipment, what we call PPE. Also, in some cases, lack of adequate guidelines. But the big reason is the surge. Just hospitals being overwhelmed by massive numbers of sick patients in the ICU. Our hospital system is such that even it's always it's sort of at near capacity anyway, because that's the business model for hospitals. That's how they stay financially solvent. So even in a tough flu season, they get overwhelmed. Now you throw this on top of it. We just heard from the New York Times this morning about Elmhurst Hospital, which is one of the big public hospitals for New York Health and Hospital Corporation in Queens. Just the devastation there and getting overwhelmed. And that's when mortality rates go up. So the reason why mortality rates are so high in Wuhan and in northern Italy, higher than elsewhere, is because they're unable to manage all the ventilators, manage all of the intensive care that's required to keep these patients alive. And that's what we're seeing play out in New York. And so the question is, what do we do about it? Well, sure, of course, you want to put pieces in place to fix the supply chain and get all the ventilators out there. But the major thing is to make certain that you can do that social distancing to reduce the number of patients who come into the hospital. I mean, that's the reason why we're being so shrill about doing the social distancing. It's to, you might have heard the term flatten the curve, and the way that, what that means is if you look at a big peak of patients coming into the hospital where it's a big sharp peak goes up and then down, that's what you don't want, because you get a situation like we have in Elmhurst Hospital in New York, or the other, or Columbia Presbyterian New York Hospital, so many patients coming in. By smoothing it out and letting it go over a longer period of time, what that does, it gives hospitals the chance to catch up, and that by doing that, you'll lower mortality, and so that's the big measure. So, and that's again the other reason why, in an understanding way, push back a bit for these calls to say we're ending social distancing for Easter. We can't do that, right? Because otherwise, not until we see a big drop off in this epidemic, because otherwise we're going to face the situation like we're facing in New York City. And we're already hearing reports now that this has taken a southern turn. So a big spike in the number of cases in New Orleans. I think New Orleans has had now has one of the highest case fatality rates, the epidemic in the U.S. And now we're just hearing from the mayor of Atlanta that their ICUs are getting overwhelmed. So
yeah, I'd like to ask about that. So obviously, New York has been described as kind of the current epicenter of the epidemic in the U.S. But as we see increasing numbers of cases in southern states, warmer climates, these are cities like Atlanta, that are not as dense as New York. They're quite sprawling. Does that change the nature of the epidemic? Are we going to have kind of a southern flavor to this? Do we know yet what that will look like?
Yeah, that's the big question. Well, one of the things that we've learned so far is that it's been mostly an urban epidemic. And so crowding is a huge component to this. I'm sorry about the sun there. Let's see if I can. My wife worked really hard to set up our home to make it look like something resembling something legitimate, but we'll just have to deal with it. I didn't anticipate. I thought the southern exposure would be the exposure be okay. This is emerging as an urban epidemic, and so that's so far what we've seen. So cities are getting affected. So density is a big issue, and that is an important factor in New York City. Now, why New Orleans? Why Atlanta? The one question about New Orleans is whether allowing the Mardi Gras to go on, whether that had an important role, and I don't think we really know that yet. What was responsible for that possibility? You know what I'm gonna do? I'm going to see if I can move this a bit.
Sure.
And
well, while you work on that, I wanted to ask something you've brought up before is talking about the possibility of a serum, I think is the word you use, essentially taken from the blood of people who have recovered from COVID-19, I guess, and trying to sort of harness some of the antibodies, or can you expand a little bit on that? And
sure. Let me just finish up one piece of the southern epidemic. One of the things, the high mortality risk. So why is the high mortality rate? Is that hospitals getting overrun? But we also have this situation where we're getting. I don't think that's it alone. I think what we're seeing, and it's really high. It looks like a 6% mortality in New Orleans. I'm wondering if it's the high rates of underlying diabetes and hypertension going on. And I'm also wondering whether it's mostly affecting people in poorer neighborhoods. We don't have the area codes, the zip codes of where this epidemic is striking, where people are getting sick. But, from news reports, I'm thinking it's more African-American populations. So this is another dimension of COVID-19. Maybe it's emerging as a health disparity in the southern part of the country. And that's something that we're going to have to look at very, very closely.
Right. And we obviously have a large, a high uninsured population here, a high population in Texas with comorbidities, lots of poverty. Is that concerning from a public health
So the point is, I think, it's our cities, Dallas, which actually has the largest number of cases of COVID-19 in Texas. Austin is second. Houston and San Antonio a little further down. We have to look at what's going on now in New Orleans and Atlanta and say, okay, well, are we next? And prepare for that possibility.
Mm. So returning to the serum question, you can, as our resident not scientist, maybe you can explain a little bit about what's going on there. Is it promising? What do we know and what do we not know?
So there's a lot of urgency now to accelerate new therapies for COVID-19, and right now we don't have a vaccine. Where our lab, our Texas Children's Center for Vaccine Development, and we're working with UTMB Galveston, the Galveston National Lab, and the New York Blood Center, and the Army, the Walter Reed Army Institute of Research. We have a consortium for developing coronavirus vaccines, and we hope ours is one of those that will advance to clinical trials in the coming weeks. And there's going to be about half a dozen of them, but Dr. Fauci says it's going to take a year to 18 months for doing all the human testing. I think that's actually optimistic. It may be, a couple of years before we have it, so that if COVID-19 comes back year after year, then that's where the vaccine's going to come in. So the question is, what can we do now? And you were hearing a lot, you were hearing a lot from the president also about hydroxychloroquine, which is an anti-malarial drug, and its potential benefit to treat people now. And some people are actually taking hydroxychloroquine to prevent themselves from getting sick. I have to say, unfortunately, the evidence for that is not really strong. There's that medicine can inhibit the replication of the virus and kill the virus in the test tube, but whether or not that really works in patients, we don't know. And there's some small clinical trials suggesting that there's a hint that it may be doing something, but it's not very strong. And
how long does it take?
The other night actually said, we actually were at that point for influenza. So chloroquine inhibits the replication of influenza, and there was a lot of excitement about it as a treatment or prophylaxis for influenza, but it didn't pan out. That was about a decade ago, and to be really effective in the clinic. So keep that one, let's see how it pans out. But I can't say I'm putting that at the top of my list of what the most likely therapy is going to be.
Sure. I mean, you're on the bench. Can you explain a little bit about why it takes so long to answer these kinds of questions? I think, there are people in this country who think we're the U.S. We've got, outstanding scientists. Can't we just put them all in a room or maybe in a teleconference and whip up a vaccine? Like, what is the delay?
Well, the delay is mostly for safety testing and efficacy testing, meaning that we can make a vaccine pretty quickly now. In fact, there's one already in clinical trials from a company in Boston out of MIT. And there'll be other ones that'll follow. That's not the hard part. The hard part is making certain that it's safe and that it actually works. And that takes time. So, vaccines especially, remember how a vaccine works. We're injecting it into someone who is not sick in the hopes that it prevents them from getting sick. So you have to be absolutely pristine in your studies. The anti-vaccine lobby, which goes after me a lot because I have a daughter with autism and I wrote a book called Vaccines Did Not Cause Rachel's Autism, likes to claim that vaccines are not adequately tested for safety. Well, actually, the opposite is true. Among the different pharmaceuticals, vaccines are the single most tested for safety. And it's a process that's been fine-tuned over decades, and it's really hard to accelerate those timelines very, very quickly. So there's maybe a few things you could do to accelerate things, but if you wind up making a vaccine that's not safe, that's even more destabilizing. I mean, this happened in the Philippines, where there was a prototype dengue vaccine that was developed, and it turned out that the vaccine, there was reports going on that the vaccine wasn't safe, and it actually interrupted this whole supply of vaccines in the Philippines, and people stopped vaccinating against dengue and other diseases, and it was incredibly destabilizing. Thousands of kids died of measles as a result. So we can't let that happen.
Okay.
The hydroxychloroquine, I think, will get a quicker answer because it's for the treatment, not for prevention. But the one I'm most optimistic about, and the one I've been talking up a lot on cable news, is this convalescent antibody therapy. This is a bit of a throwback. It was done during the 1918 flu pandemic, where you took serum from patients who had recovered from their viral illness and they have high levels of antibodies. You remove that serum, the plasma component of the blood, give back the red cells to the patient, and then inactivate any virus agents that might be around in the plasma, and then you could administer that as a serum therapy. And this worked in the 1918 flu pandemic. And now, of course, we have procedures that we can do this much more accurately and with a higher level of safety.
Sure, but what is the timeline for knowing?
Well, I think we can move pretty quickly. So now there's a network of blood banks mostly in academic medical centers, looking into that. And I think we'll get some answers pretty soon in the coming weeks. And there's two potential uses for it. One is a treatment, to take the plasma containing the antibodies and treat sick patients. And then the other is even as prophylaxis. In other words, you can give a smaller dose to healthcare workers or first-line responders and keep them safe for a period of 2 weeks till the antibodies start to decline. So I think that could be really helpful to move forward. So we've been pushing hard and talking to the FDA and to get some guidance on how to move this forward very quickly. Yeah. Again, accelerating this stuff in the middle of a pandemic is tough. It's not easy to do this, but if anybody can do it, the United States can. And I think that might be our most immediate therapy that we have. And so I think we need to push really hard on that.
Mm-hmm. As we're seeing more and more cases in the U.S., I think we're seeing greater numbers of younger people, healthier looking people becoming sick, sometimes critically so. But correct me if I'm wrong, we still believe that the virus does not appear to affect children as severely. Is that right? And do we know why that is?
So a few things about that. So the narrative that came out of China was this is a disease that had high mortality rates among individuals over the age of 70, 10 to 20% mortality rates, and especially those with underlying conditions, diabetes, hypertension, heart disease. And I think that's still true. A couple of differences, though. One, we started seeing in Europe lots of people in their 20s and 30s get sick and requiring hospitalization. Now the CDC last week came out with a document published in the Morbidity Mortality Weekly Reports, MMWR, showing about a third of the hospitalized patients are young adults between 20 and 40 or 20 and 44. And that's something that also I've been really working hard to get the message out, and why we, especially during spring break when you had all these people crowded together in the beaches in Miami and elsewhere. I'm definitely the killer of people's fun in the United States. It's a terrible role I've had, but I really think it's necessary to protect those younger populations, because somehow the word has gotten out, oh, this will only affect grandma and grandpa, and if you're young and healthy, don't worry about it. It's not true. That's one thing. Even though the mortality rates are still low among people at 20 and 44, a lot of that is because they seem to be surviving intensive hospital care better. But the ordeal of a young person being intubated in an ICU is still devastating. So we have to protect those populations. You mentioned kids. You're right. I think children are getting infected at pretty high rates, but for reasons that we don't really understand, they're not getting sick, with one exception. We're seeing pretty severe disease among infants. So kids less than 1 year of age, about 10% of them who get infected have severe illness. So this becomes very important. If you have an infant, if you're young parents, you have an infant at home, think of your infant like you would an older individual and plan accordingly.
What about pregnant women? Do we have a grasp yet on how that affects them?
We don't, and I've been talking to, so Texas Children's is not only a pediatric hospital, it's also an OB, a maternal hospital as well. It does a lot of maternal child health care. So I've been talking to a couple of the obstetricians, including my colleague Kirsty Agard, who's interested in maternal fetal medicine, and she's sort of collecting cases now of severe illness among pregnant women, and that may become a story down the line. We know, for instance, that patients of pregnant women with influenza don't do well, and that's why we push hard to vaccinate pregnant women against influenza during flu season. This may turn out the case, but we just don't have the evidence base yet.
Okay.
So if you're pregnant, the bottom line is if you're pregnant, you also want to take precautions.
Sure. My last question for you here before we open it up to some audience questions that we'll be fielding. We've talked a lot in terms of the U.S. response about testing. Obviously, there have been widespread failures in the U.S. to have tests widely available, quickly available. We've seen in other countries they've been able to mobilize testing faster. I wonder, though, at this point, given that the virus is all over the country and is spreading rapidly, how much does our testing capacity actually matter? And can we respond to the pandemic if we don't have a good understanding of who exactly is infected?
Yeah, I mean, the way this epidemic works out is in phases. You have the testing phase, and then you have the surge in the hospital phase. And unfortunately, we missed the boat on the testing phase, and this is what caught us off guard in New York and now in New Orleans and maybe Atlanta as well. Not having that testing in place, we couldn't really prepare accordingly and do the social distancing sooner. So that has been really important. And there's studies showing out of China that the longer you allow transmission to go undetected, the worse your surge in the hospital is, and that seems to be playing out. So we are now getting testing ramping up. We have a Texan now in charge of organizing the testing. My friend and colleague Brett Gerard, who was at Texas A&M, then was with us at Baylor College of Medicine. He's now the Assistant Secretary of Health, and he's responsible for gearing up testing. So I think that's going to happen. But it would have been nice to have all that in place a lot sooner.
Sure.
So we did miss that opportunity. So we still need to ramp up the testing, but now we've also got to do two things at once. We have to now prepare for that hospital surge that's already starting to happen in several cities now.
And does it mean we should be operating under the assumption that the virus is probably already here, even if your community isn't seeing large numbers of positive tests, that you should be acting under the assumption that it is?
I think you have to, and the reason is this, because right now, with testing still inadequate, the only reason you know that you've got a COVID epidemic in your community is if patients start showing up in ICUs, and then you've missed your window. So that's the reason why we do it, to do that testing in order to then enforce social distancing. And I know it's extreme, but this is what life is like without a vaccine. It's like trying to fight it with one hand tied behind your back.
I'd like us to get into some audience questions. We've seen some interest in the vaccine, like you've spoken about. Do we know yet whether this vaccine will be, potential vaccine? Obviously, you've said up to a year or more away, but in a universe where we do have a vaccine for the coronavirus, do we expect it to be similar to the flu vaccine in the sense that you need a new one kind of each season?
So the answer is we don't think so. So the mutation rate does not look that high. So the hope is that a single vaccine will last us for quite a long time. The question that we're also asking, though, is who gets vaccinated? Do we vaccinate older populations? Do we almost like a shingles vaccine, Shingrix, or like a pneumococcal vaccine? Or do we vaccinate or is it an adult vaccine for the whole adult population, especially given what I just said about individuals in their 20s and 30s? I don't think we really know that. we don't know that yet. I think that's going to take time. We'll see how people respond to the vaccine as well. Or do we give it as an infant vaccine? And it's also going to depend on whether COVID-19 does indeed appear year after year after year. Remember, with SARS, the original SARS, with this new virus called SARS-2, with SARS-1, it came on the scene in 2003, caused a pretty devastating epidemic in southern China and Toronto, Canada, and then it was gone. And we saw that with Zika as well, right? It was really rose up in 2016. By 2017, it was mostly gone, to the point where you couldn't even test the Zika vaccine to know if it worked because there weren't enough cases. But we don't know. Will Zika come back eventually? Will the original SARS come back? Or will this one come back? The problem is this, that if it doesn't come back, at least for a few years, then we've seen investor enthusiasm go way down and people lose interest. That happened to us. We made a SARS vaccine, but by the time we made it, the SARS-1, there was no more SARS around and nobody cared, and we couldn't attract any interest in people moving it through clinical trials. So we tend not to be very proactive or anticipatory in thinking about disease. So this might be a vaccine that winds up getting stockpiled. And if that's the case, that's one of the reasons why you're not seeing the big pharmaceutical companies take a big interest in this vaccine. No, who wants to make a vaccine where you're not going to get financial return? That's why it's left to a few academic nonprofit product development partnerships like ours, or some of the smaller biotechs who use the opportunity to accelerate their technology. And so there's a broken ecosystem around vaccines.
Is there any research being done to investigate whether that SARS-1 vaccine would have any applicability here? I know it's a different virus, but... Well,
that's one of the... So we have two vaccines we're pursuing. One is a one that's shovel-ready already, which is the SARS-1 vaccine. We have to get it vialed and do some additional toxicology testing, but we can move that into the clinic pretty soon. So that's one we're looking at, is what we call a heterologous vaccine, a vaccine that was designed for protecting against SARS-1, but may protect or partially protect against SARS-2. And then we're also developing a second one specifically designed for SARS-2, and we're trying to do both in parallel to maximize having those technologies out there. We're, still in sort of fundraising mode, trying to get those out. Getting some progress, but not quite yet.
Sure. We have another audience question here from Noor. They ask, if you were governor of Texas, what would you be doing differently?
It's I think Governor Abbott and the lieutenant governor are really concerned about this virus, and they've kept our infectious disease task force going, and I'm part of that. I think the key now is to make certain, and there's nothing new that I really need to tell them. They know, they've already seen what's happened in New York, and they're seeing what's happening in Louisiana. So they know what needs to be done in terms of making certain that we are ready for that surge, that we have we have the ventilators, we have the hospital staff, that we can bring in the Texas National Guard if we need to build tent hospitals if that becomes necessary. So you've got, the governor's got a good staff in place, people like Chief Nim Kidd, who leads Texas preparedness activities. They couldn't pick a finer individual than those. So I feel overall pretty good about Texas. I just be really careful about getting that sense of urgency and remembering the importance of the social distancing, because we have to protect our hospitals.
Sure. I mean, given that, what do you think about the governor would have an opportunity to issue maybe a statewide order for folks to stay at home? Do you think that's appropriate at this time?
I think it's going to be particularly important for our cities to do that, because so far we've seen these big urban outbreaks. But again, there's always risk, because this is a new virus agent, and we don't know how this is going to operate in rural areas. So far, it looks the crowding has been really important. So I would say that the priority now is to protect our cities. Of course, the big ones, right? Austin, San Antonio, Dallas, Fort Worth, Houston, but also some of the smaller cities as well. We have to be ready if an epidemic happens there. And as I say, we don't have to do this in perpetuity. Do it for the next month while we see this thing building, and then make a reassessment. And
Okay.
that would be my recommendation. But and I sincerely mean this. It's very tough. This is very tough for government officials, not just in Texas, for everywhere. The getting a state ready for an epidemic, for a new virus agent, or a country ready, is the hardest thing we face as a state, the hardest thing we face as a nation, because there's so many moving parts to this in terms of how the virus is behaving, learning about the virus, how it's transmitted. And as I always say, the new virus agents set you up to make you look bad. That's just the nature of the beast. And I think some new information is going to be coming out in a few days or weeks regarding the impact of social distancing and why it's effective. And I think that's going to be very important to pay attention to as well.
Okay. We have another audience question here. Have we, and by we I mean the scientific community, which I am not admittedly a part of, but is there any indication that there are genetic issues here concerning how susceptible a person could be to infection? We have seen these kind of large family groups sometime all get sick.
Right. Yeah, we don't know. Especially among some of the younger individuals, it's really important. We know now, as we mentioned, a third of people in their 20s and 30s, a third of the hospitalized patients are people in their 20s and 30s. That might be the most interesting part to look at from a genetic standpoint. Are there certain genetic markers? You have to remember, and it's now the end of March. This was a virus that 3-4 months ago we didn't know existed. And that actually is an impressive part of the response, that we've now, over 3 or 4 months, we've identified the virus, gotten its full genetic code. We know which host receptor it binds to in the lungs. We are starting to identify mechanisms of transmission. This is unprecedented. For the original SARS in 2003, it took over a year to figure all those things out. Now we've compressed it into a few weeks. So the science is really powerful, but there's still more we don't know about this virus than we do know. And within a few months, we're going to learn so much more, and we'll be able to compare how this epidemic behaved differently in China versus Europe, or versus New York or other parts of the United States.
I think we've got time here for one more audience question. We've seen a lot of interest. People who are staying at home as much as possible. They've got to go out. They've got to go to the grocery store, etc. Do we know yet how long the virus can live on surfaces? Maybe a grocery store cart or a door handle, things of that nature.
Yeah, it's looking like this is a pretty hardy virus, and that may be one of the reasons why it's so transmissible. So there's been one study published in the New England Journal of Medicine that looked at different surfaces and showing that the virus can stay on certain surfaces for hours or sometimes longer. Or there's been reports now that in cruise ships, this virus can live for days on inert surfaces on cruise ships. So that we have to take pretty seriously. So the hand sanitizers, the Clorox wipes, all of that becomes really important. But with all that, this is putting enormous emotional stress. The economic impact aside, there's also profound emotional distress. I can't tell you how many people I've heard from, that are watching cable news all day and hearing all of this terrible news, and it's having a big psychological effect and mental health effects on the state and on the country. And we really have to look after that. I've advocated for a system of low cost or free mental health care, either by Skype or by phone, to manage this. And I think one of the best things people can do right now is to try to spend some time outdoors, especially now the weather's nice here in Texas. Take walks, keep your social distancing, but spend as much time outdoors as you can. I think that will help a lot. Again, don't go into crowded venues outdoors, but taking walks in your neighborhood if you can is therapeutic in so many ways.
Well, Dr. Hotez, I just want to say thank you so much on behalf of myself and all of our viewers, and thank you, viewers, for tuning in. It's been a great discussion. Dr. Hotez, thanks again, and we're about out of time.
Thank you. I apologize for all the sunlight issues. I'll fix that for next time around. We're all on a steep learning curve, figuring out how to do all this by Skype.
Doing it on the fly. Well, we appreciate your time.
Thank you so much.